Yeah, thank you. Yeah, I have a very similar topic because now we are talking about the impact of the of COVID on the ICU and the healthcare workers, and I just realized that I might be one of the few frontline workers here in the room because I worked in the ICU, the COVID unit, during the first waves. Normally, I work in the OR as an anesthetist, but there was no OR schedule at that time, so I worked full-time in the ICU. So I had to contact, and that was the time when we were, of course, not vaccinated. There was no vaccine. We had no or little protection stuff to protect us. There was not a lot of knowledge about this disease, so it was a scary situation, and it had quite an impact also on the mental health. And this is the topic of my talk. These are my conflicts of interest, nothing related to this talk, but I'm proud to say that I'm an honorary Scout professor from this university, so I'm linked to this university, and I love to come back from time to time to Aarhus. So the first reports from about the mental health of the medical workers come from China, Wuhan, China, of course, because this was struck first. It was in the Lancet as early as March 2020. So they just stated that there was a high risk of infection and inadequate protection, like in our unit. There was overwork, frustration. We had to work in 12-hour shifts. There was discrimination, isolation of the patients. There was patients having negative emotions due to that, and there was lack of contact with their families and exhaustion. This led to stress, anxiety, and fear, of course, depressive symptoms. People could not sleep, and they had signs of denial and anger. And secondary mental health problems related to that, of course, is impaired attention, impaired understanding, impaired decision-making abilities, and impaired overall well-being. Well, this thing does not work quite well. Okay, so they also in China they try to intervene, and they developed a 3-step psychological intervention plan to support the healthcare workers. But the problem was that the medical staff were reluctant to participate in these measures, simply because they said we need more time to rest. This is the only thing, and they refused psychological help and stated that they did not have any problems because. Some of the reasons: first, getting infected was not an immediate worry as soon as you work in the ICU. Second, they did not want their families to worry about them. Third, the staff did not know how to deal with patients at that time. Staff was worried about the shortage of protective environment, and many staff mentioned that they did not need a psychologist, they just need more time to recover and more rest without interruption. So the first reaction also included hospital that they provided more time and space for rest, and protective measures, of course, was ordered, and the hospital security staff was involved to protect the healthcare workers from aggressive patients and families, and leisure activities were organized to cope with that mental health problems. First data came out as early as also in April, it's still March 2020. So from more than 1,200 healthcare workers in 34 hospitals in China, 60% nurses, 40% physicians, a majority work in Wuhan, where the outbreak started, and the participants reported experiencing psychological problems, most severe in nurses and female doctors, more severe in those working in Wuhan, and in frontline care workers directly engaged in the diagnostic, treatment, and care for COVID patients. There was a small interview, only 20 nurses, but very informative about their psychological burden, and they had negative emotions like fatigue, discomfort, and helplessness caused by the high intensity of the work, self-coping styles, and life adjustment, altruistic acts, team support, but there are also personal growth under this pressure, which included increased affection and gratefulness to be able to help patients, and professional responsibility, and these positive emotions occurred simultaneously with the negative emotions. Then first data out of China came from Italy. Italy was struck at the second country which was struck by the first wave. So this was an online questionnaire, and the key health care outcomes or mental outcomes were post-traumatic stress syndrome, and symptoms of depression, anxiety, insomnia, and stress were looked after. And the results, again, a big number, almost 1,400 healthcare workers participated. Almost every second of them said they had post-traumatic stress syndrome. Every fourth of them had symptoms of depression. Every fifth of them had symptoms of anxiety. 8% could not sleep well, and 22% perceived high levels of stress. And risk factors for these adverse outcomes were protective was young age. So if you were older, you were like me, you were more scared, obviously. Female sex was also a risk factor. Having a colleague who deceased was a risk factor, a colleague hospitalized, a colleague in quarantine. All these increased the risk of having these adverse outcomes or being exposed to contagion, like we all have been. So this is let's say, a meta-analysis of summary. They summarized 7 studies from Italy. The prevalence of trauma-related stress ranged from 7.4 to 35% in these studies, particularly, again, among women, nurses, and frontline workers. In comparison, in the general population, it was around 77%, so it was higher among these healthcare workers than in the general population. First data from France. This is a study from 21 intensive care units in France. And again, every second participant of respondent reported anxiety, depression, 30%, and peritraumatic dissociation, also 30%. Male sex was independently associated with a lower prevalence of these symptoms. And so the 6 modifier determinants were fear of being infected, inability to rest, inability to care for the family, struggling with the difficult emotions, regret about the restrictions, and witnessing hasty end-of-life decisions, as we had to do in those days. Then data from the UK. This was a web-based survey across 9 English hospitals, more than 700 participants, 40% doctors, 50% nurses, 10% others, and they reported, sorry, that was too fast, no, wrong direction. 45% met the threshold for significance of at least one of the following measures: depression, post-traumatic stress, anxiety, or problems of drinking. Then data from Switzerland. This is a big university hospital with 8 hospitals affiliated in Geneva, Switzerland. And they used a battery of tests like this one to assess the healthcare, the health of the healthcare workers. 3,500 healthcare workers participated, and 350 of them worked in the ICU, 74% were female, and among those working in the ICU, 40% showed low well-being, 46% symptoms of anxiety, 46% symptoms of depression, and so on. So it's, again, and all these symptoms were more severe in those people working in the ICU compared to those not working in the ICU in those hospitals. So Working in the ICU, rather in other departments in that Swiss university hospital, resulted in a change of eating habits, so more food intake, less sleep than usual, doing less sport, just heard about it, more alcohol and tobacco consumption. The worst mental health symptoms were associated with being female, the fear of catching or transmitting COVID-19, the anxiety of working with those patients, the work overload, eating and sleeping disorders, and increased alcohol consumption. And the conclusions were that the COVID-19 outbreak is associated with a high prevalence of the mental health care impairment, and lifestyle changes such as sleeping and eating patterns and alcohol and tobacco consumption were also affected. This is a European-wide survey from the European Society of Intensive Care Medicine, more than 1,000 respondents from 85 countries. I didn't know that Europe had that much countries, but maybe others also participated. Again, the same numbers: anxiety almost 50%, depression 30%. So it's a general problem. And again, female gender more prone to having these symptoms and resting problems. So, and these factors were independently associated with severe burnout in those co-workers. Well, conclusions. What about the Netherlands, where I work currently? So there was a big participation from the general population, support of us working in the ICU or in the hospitals dealing with those patients during the first wave, which did not happen again in the second wave and turned into aggression almost during the third wave. So there was an increase in the ICU treatment volume by more than 25%, from 250 to more than 300,000 days in the ICU, although we did not admit, let's say, older people with a little chance of survival to the ICU. There was a decrease in all the other admissions, so trauma admissions reduced by 20% and so on, even heart infarcts reduced. And there was a decrease in all of these elective operational program, including cancer surgery and cardiac surgery, where I work, was almost completely shut down. And it will take about 2 years to catch up with these numbers if we model this to the additional work that we have to do right now. So there was a survey about the medical specialists in the Netherlands performed in June, so very recently. 36% declared exhausted and fatigue, 15% are worried, have sleep disturbances, and 29% feel that they can't get a grip on the situation, they feel powerless. 40% had to cancel their vacation or their free days due to the COVID, and 30% of them had no chance to catch up until now with that vacation. 13% dropped out of the long job for longer periods or for forever. Another 18% are considering to leave the field. 31% want to take part in the decision making of this catch-up care, because now the hospital, now we have less COVID patients, the hospital urges us to do more operations and work on Saturdays and so to catch up this care. But the people have needs for rest, of course, and to get back their work-life balance. So after what is the situation? We have less ICU beds open than before the COVID. All of the medical staff was forced to work full time, and if Dutch people don't like to be forced to anything, it's to working full time, because no one works full time in the Netherlands. So this was a very hard decision and left many people to leave. And this. All of this led to those numbers. So these are the numbers of ICU beds in our hospital. So we have 48 physical beds. And before the COVID wave started, we had only 36 beds open due to staff shortage and so forth. During the COVID, we had to upscale until to 39 bed at max. By recruiting people like me from the OR to work in the ICU. But now, after the third wave, we only have 22 beds open, so even less than before the COVID wave, because people left and have burnouts and so forth. So this is, I think, a major problem. And now comes the fourth wave, or the catch-up care, which might be considered a fourth wave if there's not a fourth COVID wave coming. So in conclusion, different countries, same experience regarding mental health care. There's a blame and shame culture. Medical staff feels less pressure not to take necessary breaks. Every minute you are on break, a patient may die. This is one of the quotes from Italy. This is what you sign for, what you get paid for, so you have to do the job. Pressure like this. There's an ICU bed shortage, as I told you, creating medical dilemmas. So you have to do a triage. We had to do a triage at that time. Based on which criteria, the politics were not very much helpful in helping us in deciding these, giving priorities based on the survival chance. That's what we did. But there was a lack of knowledge on the evidence and what's the best therapy. So maintaining mental health stuff among staff is essential to better control the disease, but the best approach during this epidemic still remains unclear. With that, I thank you very much. I have another conclusion here. So, sorry. Yeah, as I said, there's uncertainty about the future. Will there be a fourth wave? Certainly there will, because the numbers are increasing again now after the school have reopened and due to the traveling. And this catch-up care, which with this huge bulk of patients who are waiting for their operation, could be considered another problem, and many healthcare workers still are refusing to get professional help to cope with these problems. This is really the end of my talk. Thank you very much.